A&E waits are seeing hundreds of patients in England dying unnecessarily each week. A new study from the Royal College of Emergency Medicine found there was likely to be an excess death for every 72 patients who spent 8 to 12 hours in the emergency department. And the longer the wait, the greater risk of death. Joining me now to discuss this is former NHS Trust Chairman and Health Policy Analyst Roy Lilley. Good evening, Roy.
Good evening.
Do these figures come as a surprise?
No, not really. I mean, the Royal College of Emergency Medicine has been banging away about this for ages. Let me give you the background to the numbers. The NHS calculates excess deaths on what's called a rolling average, a rolling 5-year average. So they take all the deaths over 5 years, create an average, and then they look at today's deaths compared against the rolling average. Now, the rolling average deaths went up, of course, during COVID and after COVID, and they're starting to taper off now. Throughout that period, the Royal College of Emergency Medicine have been saying, look, there are excess deaths because of COVID, of course, but there is an underlying trend here as well. And it was very convenient for the Department of Health to say, well, no, I mean, the data's complicated, it's obfuscated by COVID, and it can't be right. But now, of course, everything they've said is coming true because the COVID deaths are starting to taper off, and you can look at the excess deaths without the complication of COVID, and you can correlate them against the rolling average. And that's where the excess deaths come from. And the Royal College of Emergency Medicine is saying that the principal cause of these deaths are people being delayed in their care in A&E. And you don't have to be a doctor or a statistician, really, it's common sense. Delayed care is dangerous care. And if something like this happens, then people will die waiting. And that's the sad truth.
See, I was sceptical when I first read these numbers, these figures. I was sceptical, but you're saying that this estimation and the link between long waits, that's it, it's completely true.
Yes, I mean, there's an undoubted correlation to that because one of the confounding factors in the numbers is the fact that people are waiting a long time in A&E. And, you know, we know from death certificates and we know from cause of death really what the numbers mean. And so we've been able to spot where the excess deaths are coming from. So, and as I say, I mean, this is not new. This isn't sort of new data that suddenly come out of nowhere. These are the numbers that we've been getting as an underlying cause for some time. And of course, you know, the doctors and nurses that work in A&E, they're not fools. They know exactly what's going on. You get people come in blue light through the front door of A&E. 40% of people that go to A&E are likely to need a period of inpatient admission. Now, A&E is a magic place where, you know, miracles happen by the day, but their job in A&E is to stabilize people and to make sure that they don't lose their lives. So they're stabilized, but then they have to get onto the ward where the next layer of magic happens, where people are really cared for. They maybe go to surgery, they're looked after on the wards, and that's where the specialists come in, and then they'll see an orthopedic person or a cardiac person or what have you. So A&E kind of stabilizes the situation, then you get onto the ward. If you get stuck in the no man's land between the cardiac ward, for example, and A&E, often in a corridor because A&E is chock-a-block, that's when the risk happen. Now, you know, the A&E staff are getting quite good at managing this sort of no man's land, and even some hospitals now, or during the hiatus last year, had corridor nurses whose job it was to look after and maintain people in corridors on trolleys. But the difficulty is when A&E gets chock-a-block like that, the reason for that is that probably 1 in 3 people on the wards didn't need to be there. They needed to be discharged. Often they're elderly and frail, and they can't be discharged because social services, who are the sort of the sister of the NHS, aren't able to arrange what we call domiciliary care packages. These are the fabulous people that come in the morning and get your granny up and get her out of bed, give her a wash, make sure she has a breakfast, maybe come in for lunch, and then twilight services in the evening. Those services are really very, very important to get people home safely, because while someone might be medically fit to go home, medically fit to leave the hospital. They're not really fit enough to look after themselves at home. They're at risk. So you have to wait for social care to arrange the domiciliary care packages. Social care, you know, they've had their budget, I think their budget cuts are about 40% over the last 10 years. They just simply don't have the money. The domiciliary care sector is dominated mainly by very small companies who are just struggling at the margins. And so you get a situation where people are in hospital, could go home but can't, so they're occupying a bed, which means the people waiting in A&E and in the corridors can't get onto the ward where they get their proper care. They get chock-a-block, and then the A&E gets full, and then we see pictures of ambulances queuing up outside A&E. So the NHS is really a large sort of production line. It's, you know, sick and poorly people go in at one end, and then hopefully fit and happy people come out the other. If you get an interruption in what we call flow through the hospital, that's where the wheels come off. And that's really what we're talking about with these numbers.
Okay, so bed blocking is a factor then. I was in A&E just last week. I took my son in. We were in and out within 4 hours. It felt like a long time, but it wasn't a 12-hour wait. So I guess these figures are not reflective of every single A&E department across the country. But is there some kind of, I don't know, A&E league table of some sort where people can go and look and see where their hospital ranks? And maybe if you can drive yourself to A&E, you don't go to your nearest one. You're going to go to one 2 towns over.
Well, there used to be A&E targets, the 4-hour target, of course, but that's been largely abandoned. They're trying now to get 74% of patients through A&E in the 4-hour time. But I mean, it's really difficult to do. What we found with COVID actually is a lot of people coming in who are much sicker, and the average length of stay has gone up as well. So the dwell time in the hospital is longer. As far as diverting to a hospital where the waiting time might be less, yes. I mean, the NHS app, which has been, actually, they've done a fantastic job with it. I don't know if you've downloaded the app, but there's a lot of things you can do with it, and they're developing it to try and get some real-time numbers so people can see how they're doing. The difficulty with that is that you can imagine it's the A&E are linking up 250 hospitals throughout the country. And the other difficulty is, I mean, you and I are talking to each other in London. The big thing in London is that we've got loads of hospitals. But in big parts of the country, major parts of the country, there is really only one, what we might call a district general hospital. So there isn't a lot of choice, and there aren't choices about where people can go. So we do depend on the efficiency and the throughput of the hospitals.
Okay, well, thank you very much, Roy Lilley, for your time.
Great pleasure.